Good evening, everyone, and welcome to the COVID Conversation Clinic. This afternoon, I am pleased to bring you the community forum that's really created to bring you some factual, up-to-date information to the Black community about COVID-19, from vaccines, from various trusted resources. We hope to have a very active conversation with a wonderful panelists of esteemed presenters. And so I am going to give you an overview of just a few words about each of our speakers. And then from there, we will go into a robust discussion, and hopefully we can answer all of your questions. Our first presenter is Dr. Barney Graham. He is the Deputy Director for the Vaccine Research Center at NIAID at NIH, and he is the Chief of the Viral Pathogenesis Laboratory. Following him, we have Dr. Patricia Whitley Williams. She is the Chief Division of Pediatrics, Allergy and Immunology and Infectious Diseases at the Rutgers University Robert Wood Johnson Medical School. Ending our conversation is Dr. Stefan Wallace, who is the Director of External Relations for COVID-19 Prevention Network and a staff scientist at the Vaccine and Infectious Diseases Division at the Fred Hutchinson Cancer Research Center. Following the opening remarks by each of our presenters, I will also give you information about the Johnson & Johnson presenter. We had hoped to have Dr. Vicky Cardenas with us from the J&J R&D program, but unfortunately, she's not going to be with us this afternoon. We hope that we can answer all of your questions. So is Dr. Barney Graham on board? If he is not there, we will start with Dr. Patricia Whitley Williams in your first introductory remarks. Thank you, Dr. Williams.
Good afternoon and good evening, depending on where you live. Thank you so much, Dr. Brown. I'm delighted to be here and really appreciate this invitation because we enjoy having these conversations about COVID. As you heard, I'm a professor of pediatrics and chief of the Division of Pediatric Infectious Diseases at Rutgers Robert Wood Johnson Medical School in New Jersey. I'm also the Associate Dean for Inclusion and Diversity at the medical school. I also wear a couple of other hats outside the institution. I'm currently the president of the National Foundation for Infectious Diseases, a foundation that was founded in 1973. It is a nonprofit 501c3 organization that is dedicated to educating the public as well as healthcare professionals about the burden, the causes, prevention, diagnosis, and treatment of all infectious diseases across the lifespan. So all the way from babies, even before they're born, all the way to our seasoned members. I can tell you that we have been busy with this pandemic. In my role as a pediatric infectious disease consultant, I saw firsthand the devastation of COVID-19 pandemic and what an impact it has had on our communities. While you probably have heard that children are usually not as sick as the adults do when they get infected with the COVID-19 virus. But our hospital has had close to 150 pediatric admissions, and they've been mostly school-age children and adolescents. So the little ones tend not to be very sick from COVID at all, even when the mothers are infected with COVID and the baby is born. The newborns may test positive, but they are not having any symptoms. They are well. But our school-age children, our adolescents, when they get COVID, they're admitted just like the adults with pneumonia and difficulty breathing. Some have to go on the breathing machine or ventilators, but usually they survive. And then there was this syndrome called multi-inflammatory syndrome in children. You may have heard about it, MISC. And the way they present, their heart muscle is actually weakened. But guess what? They improve and they tend not to have, as far as we know, any long-term effects. Their heart muscle, maybe because they're young, they heal without any problem. But we can talk a little bit more about this later. Personally, I lost two very close friends to the pandemic last April when it was certainly peaking. And one friend was never admitted, went to the emergency room a couple of times, seemed to be getting better, then all of a sudden collapsed at home. This was devastating. And the other friend, dear friend, was taken off life support after a little over 30 days being on a ventilator. So these over 500,000 deaths that we're hearing about every day from COVID-19 are real people. These are people with lifelong stories and dreams and hopes and wishes and loved ones. So this has been obviously a pandemic of just unknown proportions and just totally unexpected. I have been a member of the National Medical Association for many years. I'm a proud member of the pediatrics section. And we usually do talk a lot about immunizations, but who would have known that we would be facing this crisis? The NMA is an organization of mostly African-American physicians, many of whom practice in the Black and Brown communities across the country. So it's a representation from rural, from urban areas. The National Medical Association has been, for over 100 years, the leading voice for quality healthcare delivery and the elimination of health disparities for African Americans, for the uninsured, and for the poor. I was asked to just talk a little bit about the task force that we formed. I am a member of the National Medical Association's COVID-19 task force on vaccines and therapeutics. And this task force was formed last spring and has served under the leadership of the chair, who is Dr. Leon McDougall, who's also the president of the National Medical Association. And he has just done a tremendous job and really provided much dedication and hours, I know, of commitment to this task force. As the COVID-19 was being reported, persons of color and our communities were being disproportionately affected by this pandemic. The NMA took up the challenge to play a major role in advocating for our communities, to educate our physicians, our membership, but also the public. We tried to increase awareness about the symptoms and the importance of timely going to the physician or timely access to care, to increase the awareness about participation, especially of people of color, in the vaccine clinical trials when they began. We'll talk about this also a little bit later and why this is so crucial and so important. That if there is a vaccine going to be developed, we have to be part of the clinical trials. So we will know that it is safe to use in our population as well. The NMA task force also participated in the discussion about the vaccines, and this was very important. Our president and our chair of the task force reached out to the pharmaceutical companies that were producing these vaccines. Pfizer and Moderna and J&J and AstraZeneca, et cetera, and requested that they meet with the task force. And indeed, this took place. This was unprecedented. This was before any vaccine was approved for emergency utilization or emergency use by the Food and Drug Administration. And we actually met virtually. We asked our questions. There are many myths that were circulating in our communities. We asked about the contents of the vaccine. We asked about the participation of underrepresented minority persons on the clinical trials. We asked about the side effects. And I would say there are about 40 questions that we went through with each company. And we also learned about some of the experience in the overseas trials as well, and what the breakdown of ethnicity was with those studies as well. So this was very important. And I think it's the first time that this probably has ever happened, where pharmaceutical companies have met with the National Medical Association, specifically around vaccines that were being developed prior to their being approved, whether for emergency use or approved for licensure. Since March of last year, the NMA, not just the task force, but yes, persons on the task force, but the NMA as well, has conducted many webinars across the country for both our physicians and healthcare professionals, but also for the public to provide education about COVID-19 pandemic. What are the symptoms? How is the virus spread? Who is at greatest risk? How can one protect themselves? Getting the message out about washing hands and the importance of wearing masks and not going to work if you're sick, and the social distancing, the 6 feet distancing. And this was actually being done before the vaccines were available. Very, very important. And also then as treatments became available, because that was shifting and changing day by day, week by week. So it was important to get the information out to our membership, our physicians. Here are the newer treatments. Some of the treatments initially that were being used, all of a sudden were no longer being recommended because maybe a study had been completed and it was found that a certain medication really was not beneficial to treating someone who had COVID-19. So we made sure that information got out to our membership as quickly as possible. And I think the importance of the NMA being front and center in the midst of changing in treatments and vaccine trials, et cetera, it was so important because our membership, our physicians said to us, I'm not going to recommend the vaccine to my patients unless I know it is safe. So that really made a huge difference, and that we did seek the information, met with scientists from the pharmaceuticals and even from CDC. And it was very important to get that information to our membership because they were the ones who patients were going to go to and say, Doc, should I get this vaccine? And they needed to be educated and be well informed so they could then inform their patients as well. And I think that was crucial. It was done early on before any of the vaccines were available. So
thank you, Dr. Whitley Williams.
I'm going to stop here and thank you very much for inviting me, and I look forward to the questions. Thank you so much.
Thank you so much. And now we'll hear from Dr. Stefan Wallace.
Thank you for this opportunity and for the invitation and partnership in this process. I'll be a little brief. Stefan Wallace, as you mentioned, Director of External Relations for the COVID-19 Prevention Network, the HIV Vaccine Trials Network. I wear many hats in addition to those, also clinical assistant professor in global health at University of Washington. And I'm also actively involved in community spaces. So I serve on a number of community boards of the various organizations, including board chair of the House of Blahnik. So I'm a part of the House and Ball community as well. I think it's really important to acknowledge where we are with this pandemic and to acknowledge that many communities, although the conversation topics have changed over the last months and really the last year, that many communities still have questions and concerns. And these questions are questions that I hear often about, how do we process this information? What does all of this really mean? I would like to offer that the COVID-19 Prevention Network has been completely involved in partnership with communities regarding the COVID-19 vaccine trials from the very beginning. This is really a part of the ethos of our work to meaningfully involve communities in the process of clinical trials, and not just in terms of implementation, but also how we think about designing clinical trials as well. And this also happened with the COVID-19 trials. So where we are is that communities have been actively involved in. Dr. Whitley Williams mentioned some of the relationships with the NMA and other groups that have been connected to these processes. But I just wanted to offer that, and to also mention that we're in unprecedented times at this time, and while there are 3 vaccines under emergency use authorization, the opportunity for viral variants, as well as some people not practicing the physical distancing and masking or getting vaccinated, places our communities at potential risk for increasing our impact, the impact of COVID-19 in our community. So I'm looking forward to the questions from everyone, and thank you again for having me involved.
Thank you so much, Dr. Wallace. I know that Dr. Graham is here now. I don't see him. Good, there he is. Well, Dr. Graham, I hope you're ready to chime in. We haven't started with the questions, but we're just giving the overview. So please join us.
Okay, yes, thank you. And I'm sorry to be a little late, but I'm Barney Graham. I'm Deputy Director at the Vaccine Research Center on the NIH campus in Bethesda. And I am Chief of the Viral Pathogenesis Lab. This is where a lot of the early work was done to understand the spike protein on coronaviruses. And so I'm here in part to tell you why we were able to go so fast, and a little bit more about how the vaccines were made. And I think in order to get to the question and answer time sooner, I just want to say that this is based on years of work, 20 years of HIV work to develop the technology, work on other viruses to show the way a protein shape can affect how it works as a vaccine. And then about 6 years of work on coronaviruses directly, and even about 3 years of work showing that a coronavirus spike for a MERS, a Middle East Respiratory Syndrome coronavirus, could be made as an mRNA and used as a vaccine to protect against that kind of viral challenge. And so that's, we knew a lot before this coronavirus happened, and we'd already had the partnerships in place to go fast because of a program on pandemic preparedness. And so there was a lot of work that went into this for several years, several decades, that allowed us to go very quickly during this last year. And I'm hoping that in the future, with even better preparedness, we could have gone a little bit faster, and maybe even taken another month or 2 off of that timeline, because as everyone can see now, getting into the vaccination phase of a pandemic response turns out to be very important for controlling the outbreak. So I'll stop there and look forward to getting into the questions, and very much appreciate being here with everybody.
Thank you so much. I will just present a statement. We certainly had expected to have a representative from Johnson & Johnson with us this afternoon, but I'm sure for many of their the organization's reactions, et cetera, they have to address the statement that has been made by the CDC and the FDA. I should make it very clear for all of our listeners, this is following the process of safety. We always want to be safe. And so that is why we have a data safety and monitoring committee. And when we have adverse reactions occurring, we stop and evaluate them. Now, there are some adverse reactions that we know will occur because in the clinical trials, they have been detected, and we ask people to report them. When that is done, we can then make a determination whether the significance of those reactions would preclude not doing further work. It is always important, and I'm sure you've heard in the past for other vaccines and other products coming to the market, that they had a pause to evaluate the information. And this is following the general process. So that being said, I'm sure there are questions that we will address in our chat box to further preclude this, because I'm sure you're wondering many, many things. But we have other questions. And one, as I want to certainly indicate, that the United States really is facing the response to this tremendous disease. And we are almost at the point of reaching our fourth wave. And you're hearing about certain states that are beginning to see a rise in their hospitalization. Hopefully, we're not seeing a continuous rise in the death rate. But this is why we're bringing you this information. Hopefully, we can answer your questions, we can alleviate some of your anxiety, and we can move forward with getting the population evaluated and vaccinated, because the disease is far worse than getting a vaccine, and we are trying to prevent the number of deaths. So let me start with some questions that we have. I know that, Dr. Graham, you've given us an overview of those vaccines that have been approved. Can you talk about the diverse use in these clinical trials to get them to being approved as a emergency use authorization? So the representation of a population diversity.
Right. Well, a lot of effort has gone into that. There's been at least 4 big vaccine trials done in a consortium of government network clinical sites and the clinical research organizations that work with the companies. So big trials for the Moderna and the Pfizer mRNA vaccines, 30 and 44,000 people. For the J&J or Janssen vaccine, another 30 to 40,000 people, and another big trial for Novavax and for AstraZeneca. So there's been almost 200,000 people enrolled in vaccine trials to test these different products. And so, can you remind me of the question?
Well, again, we're just looking at the diversity. Since we have over 200,000 or so, is it representative of the people that looks like the mosaic of America?
Right, right. And so what you'd like to see is that the proportion of different demographic groups would represent the severity of the disease that's happening in the community. So that would mean a lot of older people. It would mean a lot of minority people. Black and brown communities would be highly represented in the studies. And a lot of effort was put into that. It's not what I would like. I would have liked to see 30 or 40% enrollment of African Americans, for instance, to represent the level of disease severity in the community relative to other communities. In the Moderna trial, the one that I was most involved in and the vaccine that I was most involved in developing, around the end of August in 2020, we had everyone agree to stop enrolling white people so that we could increase the number of Black and brown people in the study. And so those last 2 months of enrollment were almost entirely Black and brown people, allowing the percentage of Black and brown people in the study to go African Americans up to around 10%, and Latinx people up to around 20% of the total population. So that was respectable, but as I said, we need more and more involvement of minority communities in clinical research so that the products that are developed can be developed for you, by you.
Good. Thank you so much. A question, Dr. Wallace. There's been a question about efficacy. You give us some statement, and what does that actually mean? Because we hear numbers 66, 94. What does it all mean? Break it down for us. So that's for you, Dr. Wallace.
Can you hear me?
Yes.
Okay, great. So when we talk about efficacy in a clinical trial, ultimately what we're doing is talking about the proportion of people who got the virus or disease based on the study, who were in the vaccine arm, versus those who got the virus or the disease who were in the placebo arm. So we're looking at the efficacy in that way, and the percentages. I tend to tell people not to really get caught up in the percentages, particularly when we think about the way that they're described in the media, because I often don't think that they're described well. And so all of the vaccines ultimately they work really well to do the same thing, which is reduce or prevent serious symptoms, reduce hospitalizations and deaths in communities. So this is ultimately what we're looking at. These are how the trials were designed to test the vaccines. So when we think about the efficacy, this is what we're ultimately talking about.
Okay. Dr. Whitley Williams, should we require children to be vaccinated before they return to school? And we know that we're now dropping it down to getting those vaccinations. And I should say, not only the children, but what about the teachers? So can you speak about that for children and vaccinations and the safety thereof?
Yes, thank you for that question. Definitely, we as pediatricians, we do want our pediatric population to be immunized. As you stated, there are 3 actually clinical trials that are ongoing for children. The 12 to 17 years of age actually is, I believe, almost finished enrolling. And now we're really looking at the 2 to 12 year age group. But it's very important to vaccinate the children. There have been some studies that have been done that, in fact, one in South Carolina in August and September of 2020, where actually the infection rate was low. It was less than 1% for both the children and the teachers, although the teachers were a little bit higher than the children. And that was even prior to vaccine. But again, practicing wearing a mask, good hand washing, social distancing, effective cleaning, of surfaces and the facility itself. So yes, I think it will be helpful to immunize our children going back to school, and definitely our teachers. As you know, there are some states who are offering vaccine to anybody 16 years and above. But the aim is definitely to get the teachers immunized so they'll be protected. And not just the teachers, but the teachers' aides, the custodial staff, the administrative staff, anybody who has contact with the people who are going to school.
Yes. So now I have a question for the entire panel, and if all of you can speak to it or just one of us. When we talk about, and we're hearing a lot in the news about variants with various numbers, and they've tied them to various countries. And when we talk about vaccines, what is the impact of the transmissibility of these vaccines on COVID-19? And should a different variant impact people in a different way? Who would like to address that? Or would you all like to address that?
I can start with that. The variants, it means a mutation has occurred. And we know that these kind of viruses, these kind of coronaviruses and other RNA viruses make a lot of mistakes when they replicate. And so they generate a lot of mutations. And the purpose for that, for the virus, is to learn how to select viruses that can be more easily transmitted or can infect human cells better or last longer in humans so that it can survive. So that virus is still adapting to improving its ability to transmit from human to human. So the virus has generated changes. Some of those changes are in the spike protein, which is the main ingredient for the vaccine. The spike protein is what's on the surface of the virus so that it can attach to a cell and then help it get into the cell. And the vaccines are designed so you can make antibodies against that spike protein and keep the virus out of the cell. Some of those changes in the spike protein, in one of the worst variants, it's 9 out of 1,273 amino acids that have changed. But some of those are in a place where it does diminish the ability of serum from vaccinated people to block that virus or stop its infection. But we don't think it's enough to keep it from being effective still. Now, there probably will be additional variants, and eventually a vaccine would need maybe some updating, but that process is already being done. So the variants are being screened for, and some of the companies, including Moderna, has already started a clinical trial with a spike made with the new variant sequence. And we know that that can work in animals. We've already tested that. And so these variants are going to come. You'll eventually probably have to get a boost with another vaccine eventually, either because your immunity has waned or because a new virus has come up that needs another vaccine. But for the next season or so, for now, I think everybody who's been vaccinated should have pretty good protection against any of the viruses that are out there.
Okay. Any other panelists want to address that? No? Okay.
I just think it's a reason why it's so important for more and more people to be vaccinated, because otherwise this does allow the virus, as
Right.
Graham just explained, to change. It's also fighting to survive. So the more we have vaccinated, the fewer people we have infected, the less chance that virus will develop different variants.
Okay. I have a question from the chat box. It has been reported that some people have taken the J&J vaccine and they've suffered some allergic reaction. Many are now afraid, is this a serious problem? And we know an allergic reaction has been reported for all of the vaccines. Who would like to address that?
I can talk about that.
Okay.
If you wish.
Go right ahead.
Yeah, so for the J&J vaccine and for the AstraZeneca vaccine that's not being used yet in this country, these are both based on what we call adenovirus vectored vaccines. And to my knowledge, so far, those vaccines have not caused allergic reactions per se. They have been associated with some syndromes that involve clotting. And that's what Dr. Brown was talking about at the beginning here, that the FDA has put a brief pause on the J&J distribution until they can communicate with healthcare providers about how to treat something if it does happen. But these are very, very rare events. They are only happening around 1 out of 1 million cases. And so it's not a very common thing to happen, but it is a serious thing to happen. And one of the reasons this has been paused is so healthcare providers can be made aware so they can treat people in a particular way with this kind of a problem. Now, the mRNA vaccines have been associated with some allergic reactions, some serious allergic reactions called anaphylactoid reactions. And that means you have a serious allergic reaction to the vaccine within about 15 minutes or so after the vaccine is taken. These are also very, very rare. It's happening about 3 out of 1 million or 6 out of 1 million. And this is a treatable problem, but it is a serious problem. It's one of the reasons I recommend people to stay for 30 minutes after the vaccine instead of just 15 minutes. But so there are some rare events happening with these vaccines, but for the most part, they're treatable events.
Okay. When we have a pause in the vaccine, such as we have with the J&J, and the people are getting a little anxious in the community, wanting to know if it's safe, will they need to get a second vaccine? And should they seek medical attention in addition to what is on the news? Can we discuss that just briefly? Who's going
I
to
think,
go?
I think anytime,
Dr. Wallace, did you want to jump in? Now, certainly, please, if you have any concerns, call your healthcare provider. They're actually tomorrow, the CDC, and there's a committee, an advisory committee to the CDC, will be meeting, an emergency meeting tomorrow to discuss just this. And I only mention that because it's open to the public. And you can go on the cdc.gov website and look for the ACIP meeting. But having said that, if you have any concerns and you just had the Johnson & Johnson vaccine, or if you got it 2 months ago and you're concerned, please call your healthcare provider. My understanding is the reactions that were rare that did occur, the clots, occurred within a couple of weeks of having the vaccine, although there were some that occurred after that time period. But again, know the symptoms, I guess, of, having a clot. If it occurs in your lungs, you may have trouble breathing. If it occurs in your lower legs, you may have some cramping and some pain in the back of your legs. If it occurs in your blood vessels in your belly, you may have some pain in your belly. If it occurs in your head, then in the blood vessels in your head, then you may have a headache. But again, any concerns, please contact your healthcare provider. It's very important. Anybody who's been vaccinated, remember you also were introduced to V-Safe. So you've been recording your symptoms there as well. Okay,
Dr. Wallace, did you want to chime in?
yeah, just about the clinical trial piece and the pause piece, and in the clinical trial space, you mentioned 3 of the companies, and so I think it's important to acknowledge that safety pauses are something that are sort of common in clinical development. And so much so that there are processes and steps in place to ensure that people's safety is being considered, is being centered, and that people are being looked after in this process, whether that was persons in the clinical trial or persons who are getting vaccinated in community spaces, as Dr. Patricia Whitley-Williams just referenced about the V-Safe program. So these are expected, and while this sort of pause happens, there are independent experts who are sort of analyzing the information and looking at this really closely to find out whether or not this is really related to the vaccine. And as part of this process, I will offer that I think it's really important that we contextualize these events also and understand that causation or correlation doesn't often represent causation. And so something can be a part of the narrative or the story, but that doesn't mean that it was caused by it. Because I often hear questions from people like, oh, I just heard someone died on the news because they got the vaccine. I'm like, well, no, they may have died and they may have gotten the vaccine recently, but the vaccine was not the cause of them dying, right? So I think it's really important that as we continue to, take in information, that we sort of analyze and we sort of ask questions, and ensuring that we're continuing to ask the right questions to increase our understanding and knowledge around this. Thank you.
Very true. Again, in part of the pause for the J&J vaccine, the question also was, do they need to take a second dose? And the J&J vaccine is a single dose vaccine, and there should be efficacy in relation to that one dose. So would you
Yeah,
recommend second
so
dose?
they started I know that they started a trial to look at a 2-dose regimen. And so, the results of that are forthcoming. But as Dr. Graham mentioned, at some point, we're going to be talking about booster shots for these as we think about when the vaccine efficacy or effectiveness wanes or decreases. But the duration for all these vaccines hasn't been identified or determined yet. So we're still a little bit premature, but I think it's really important that we continue to stay engaged and continue to ask these questions.
Yes, and I think that's why we're trying to update the community, because we are learning as we go along. This disease is moving along, and anytime we have new information, we want to bring it to provide this update. And just as you've heard, a question is, do we need to have a booster? Is it yearly? We don't know the answer to that, but this is something that we are learning. Here is a question. Let's see. We talked about variants. How many adverse events need to happen before a vaccine process is followed? Is there an answer to that question?
It's not a particular number. It's really based on a pattern. And for rare events, it's based on, how often would this happen ordinarily? Because even this very rare cause of central venous sinus thrombosis that's been reported, people are talking about today, that happens in ordinary people during ordinary life. And the thing that caught the FDA's attention mostly was that in this case, it was also with low platelet count. And the treatment of this may be different than what you would ordinarily do because of the low platelet count. And so a lot of the reason they're pausing right now is to make sure physicians are aware that this condition may need an alternative treatment to what they would have. So these things are based on patterns as much as it is a particular number. And it's compared to what would ordinarily happen as a background in an unvaccinated population.
I would also offer that severity is also a consideration.
And severity.
Thank you.
I would also like to just make sure that the listeners know that there are at least 4 systems nationally that are used to look for, monitor, or do surveillance for serious side effects or any side effects to the vaccines. And that's been very useful. So for instance, if an adverse event was reported, such as a thrombosis in the European population, it allowed us to go and look through the information that had been collected so far through our safety monitoring systems to see if that was an adverse effect or symptom that was occurring here. So those safety systems that have been set up, and some of them have been in existence for years, are extremely, extremely important. And I think the public needs to know that there's monitoring. And the other thing is, of course, that the companies, the manufacturers of the vaccines, oftentimes will have what they call post-licensure data or studies where they're still following patients who were involved in the clinical trials to see if there are any long-term or effects or adverse effects that need to be investigated.
Yes, and I should say that all of the vaccines that we currently have on the market are under what is called the emergency use authorization. They have not been fully approved by the FDA for utilization. Data is being collected, and we want to have all of this data to help when the final decision comes to give full approval.
Exactly.
Let's talk about some of the myths that we happen to hear. And this is a question for you, Dr. Whitley Williams.
Oh, okay.
What do we know about the COVID-19 vaccines in pregnant women? And there are some myths that will go along with that I'll bring up in just a moment.
Okay, I'll save those for you. But there are myths. First of all, our two national organizations of obstetricians and gynecologists in this country really have advocated for pregnant women to be immunized. What we do know is when pregnant women become infected, particularly with viruses, it can be devastating. They can become seriously ill, and it can produce serious harm to both the mother and the fetus or infant. And so it's very important that pregnant women be protected. There is a pregnancy registry, which means, and in fact, if you're vaccinated, you see V-Safe ask you if you're pregnant. Certainly they are keeping a registry, as well as the pharmaceutical companies are keeping pregnancy registries. Some people were inadvertently, or were vaccinated in the clinical trials, and then it turns out they were pregnant. So they actually, they're also being followed. And so far it's being tolerated, and certainly we want to protect pregnant women. I can tell you in newborns that are born to infected women, they can be infected, but they usually are not symptomatic at all. We're not seeing any adverse effect on the infants. Yes, pregnant women can be immunized.
Yes. Well, one of the myths is, and you can say whether it's a myth or a fact, but I have it listed as a myth. Will the COVID-19 vaccines affect your fertility?
I thought that's what you were referring to. And the answer is no, it will not affect your fertility. And I think people are talking about future birth and being able to conceive. That is a myth, and that's been shown. And so, no, we really want to protect the woman and people, certainly young women and all women in their childbearing age. We don't want them to become infected with COVID. And we know the vaccines are effective in preventing serious illness and hospitalization and death.
I would say women and trans men and other persons who are able to give birth.
Yes.
Thank you. That is actually very important.
Very
we forget about that. Thank you.
A question, and I'm not sure whether they mean the disease or the vaccine. It's how long does shortness of breath last after COVID? If you can address that in relation to the disease or following a vaccine. I don't know of that as being a side effect following the vaccine. So who would like to take that?
Can you repeat the question?
Yes. How long does shortness of breath last following COVID? And I think they're probably referring to the actual infection versus the vaccine, because I have not known of shortness of breath to be an adverse event from the vaccine.
Yeah, I personally know people who have who've experienced COVID-19 and have been hospitalized who have still shortness of breath, memory and cognition concerns, 6 months, a year later. So I think it's, there are studies that are going to be looking at long-term impacts of people in COVID-19, but I would say that it's ongoing.
Yes, certainly from the disease, but I don't know of, and I'll ask Dr. Graham, have you heard of shortness of breath as a side effect or an adverse event from the vaccine?
I haven't heard of that as a side effect of the vaccine, no.
Yes. So it's generally, as Dr. Wallace has said, from the disease, and certainly it can be long-term. And so you have those long haulers that we're beginning to look at those symptoms. And certainly I know from having a sister that had the infection, and she's still having some weakness. And it's been 9 months, almost a year.
Wow. I think some of the other symptoms include fatigue. Many people seem to have fatigue for months later, and some also say they never regain their sense of smell or taste. I've also heard patients discuss that as well.
Yes. A question. It has been reported that some people who have taken the J&J vaccine that we ask about the allergic reactions, and we answered that. Is it true that if you have had the first and second dose of the Moderna or Pfizer vaccine, you should have a booster? If so, why?
Well, that kind of thing is now being tested in people who were originally vaccinated back in March or April of 2020. So when those phase 1 trials started back then, those people are now about a year after their initial vaccination and they're 12 months after their second vaccination. They're now being studied with a booster vaccination to see what kind of good that would do for them in terms of protection. And the people who were vaccinated in those phase 3 trials are still being followed to see if there is a change in protection over time. So all those questions are being answered as we go forward, and it's hard to say how long protection is going to last and whether you'll need a booster until we see, until more time goes by, and until we see whether a new variant might come up that would need a new type of vaccine.
Okay.
I do want to just add one thing about the fertility. And, during those phase 3 trials, there were several dozen women who ended up getting pregnant during the trial, even though that was recommended against. And all of those births have not had any reported issues. And there's now been over 78,000 pregnant women immunized with the vaccines that are out in emergency use. And there have not been serious outcomes. It's very similar to unvaccinated women. And just the final thing, my youngest daughter took the Moderna vaccine, and I recommended it. And there's no way I would recommend anything to my daughter if I thought there was any chance that it could harm her anyway.
Thank you.
Yes, and we have all been vaccinated, and so again, may have had mild symptoms. I had no adverse events at all. Wasn't slight pain in my arm, but that went away, and nothing happened there. How many vaccines have been FDA approved?
0.
Vaccines for COVID, but vaccines for all kinds of things.
Well, I think the word approval is used a lot in community spaces in particular. So I think it's important to make the distinction that none of the vaccines are currently licensed.
Okay.
But they are actually, we do have 3 that are approved for emergency use.
Yes. And many other vaccines for other causes like diphtheria and pertussis and measles and the list goes on and on.
There's 18 antiviral vaccines that are approved for use.
Wow.
The 18th one just was recent. It's the VSV for Ebola.
Okay.
So there's 18 total antiviral vaccines.
Yes. If I have taken my first dose of Pfizer, however, due to bilateral lymphedema in my arms, I had to get the shot in my buttocks. Will the shot still be effective?
Well, fortunately, there's lymph nodes close to the surface of anywhere in your body. And so what happens with that vaccine is that the muscle cells or some of the other cells that can move into the lymph node will take the protein that's made by the vaccine, take it into the lymph node and start the immune response. And so you have lymph nodes close to your arm, for instance, in your armpit, and you have lymph nodes close to your buttocks where you would have gotten that other vaccine. So I don't think it matters as long as it's put in where it can do some good.
Okay, thank you. Any other comments on that?
As long as it's given right into the muscle is the main thing. So, that's also important.
Okay. Another question from the chat box. Is the central venous sinus thrombosis a concern for men, or is it only for women? Who would like to address that? This is being investigated and will be addressed on the ACIP tomorrow as they look at. I don't know if data has been released as to the gender of the individuals that have reported the adverse reaction. Is there?
So far, the 6 that have been reported are all women between 18 and 49 years of age.
Okay. So we don't know if it's going to affect men, but so
we don't know, right?
Yes. Okay. Let's see, before I go back to one of the questions that I have, another one from the chat box. How can you get younger people engaged in getting the vaccine? Anyone want to jump in? How do we put it on social media and do a TikTok, get your vaccine? Perhaps that's one way to stimulate an interest.
Make it a TikTok challenge.
What I'd really like to see is for the young people to get so excited about vaccines that they would all want to become scientists and start making the next generation of vaccines. That's what I'd really like to see our young people do.
Yeah, I agree with you. That sounds wonderful. I think if we point out that actually it's a younger age group that is accounting now for more of the cases of COVID-19, whether that's because we started out immunizing the elderly who definitely were more at risk based on our experience in the spring. But it is important for people like between 40 and 60 to be immunized, or 30 and 60 to be immunized. We have seen an increase in that age group. Some of that is just not following guidelines also in terms of mitigating the spread of this virus, and social distancing, the same thing, hand washing, social distancing, wearing a mask, cleaning surfaces, just being respectful and wanting to be part of the public health solution to hopefully end this pandemic. So it's difficult to convince, I think, younger people who believe they're invincible and that it will not affect them. But obviously we have seen deaths in the 20 to 40 year age group. So I think it's important. We have a vaccine. It's wonderful that we have actually 3 vaccines that are effective in preventing serious illness and hospitalization and death. So I think it's important. We did a survey at the National Foundation for Infectious Diseases, and we found that women, particularly women of color, were more likely not to want to get vaccinated. And the age group indeed was the 35 to 45-year-olds. Very interesting. And it's of concern because oftentimes the women sometimes do make the decisions about healthcare in the household. So I think, if we're ever going to get rid of this pandemic and socialize as we did before, it is so important to get vaccinated and continue to wear masks and wash hands and social distance.
Yes.
And just as Dr. Wallace said, we might have to do a TikTok challenge so they can stimulate interest in others and see Whether
Yeah.
the East Coast TikTokers can beat the West Coast TikTokers, I don't know. We should come
I
up
like
with
that.
something that would stimulate their interest and for them to really understand the seriousness of this
Absolutely.
disease. It's so something should be done, but I think really listening to them where they are is important and not trying to force
Yes.
them to get the vaccine, but to understand why is it they don't think they need a vaccine and really helping them to see how this
Yes.
disease can impact them is something that is there.
Yes.
And since you brought up elderly, let's talk about another question. How can we increase access to the COVID-19 vaccines for marginalized populations, the elderly, the homeless, the incarcerated, and other groups of individuals? Who would
I
like
can,
to answer that?
yeah,
Go
I
right.
can speak from our state, because this was obviously discussed, I'm sure, as it is in every state health department or Department of Health, and, whatever advisory committees have been set up to look at the distribution of the vaccine. We started partnering with community-based organizations, some of the churches, faith-based, also finding sites in the community to establish vaccination sites so that people would not have to travel, and that they could do that. I know mobile vans have been used, although that's a little bit more difficult because you have to be observed for 15 to 30 minutes vaccination. But those have been some of I know my church immunized about 3,000 people first time round. They used the National Guard who actually came. They went through FEMA. So I know that was a very good example of ways to get immunizations out to the community. And I think partnering with community-based organizations in the community and letting them be part of the solution. They best know how to get the vaccine out. So whether it's faith-based or not. The other thing we did was the homeless. So, and in fact, as you know, the J&J vaccine was designated to be used for the homeless because it was a one dose and because of the transient nature of that population. And the same with incarcerated. Again, because oftentimes people are moved and they're waiting for court dates and so forth. So I think that discussion has to happen at a local and a state level as to how people who are hard to reach are going to be offered the vaccine.
Yes. Any other panelists want to comment on that? Stefan?
We're seeing a lot of this across the country in faith-based organizations through our work on the Faith Initiative for the CoVPN, as well as HIV service organizations. I continue to hear that, the HIV service organizations, HIV/AIDS service organizations have the inroads, they have the infrastructure, and the tactics, to go out and to engage communities regarding
Exactly.
taboo and stigma topics associated with HIV. So these organizations are perfectly positioned, I think, to also provide support around COVID-19 vaccination and education. So again, utilizing the infrastructure that's already in place for communities, and you don't have to reinvent the wheel.
Very true. And it's, as you've indicated, I think community organizations, churches, and even provider organizations are very important, whether you're involving the pharmacists and the doctors and the dentists and social workers and all of those groups working together to make sure that the vaccine is getting there. Here is another question. How is data being collected on the vaccines? Number of people being vaccinated, number of people having the disease, side effects. Is it broken up by gender, by race, all of that? Who would like to speak on how data is collected? Because it's really important for us to to have this information if we're going to plan, and the question will come along, we looking at, and we shouldn't just focus on today, what is going to happen for future pandemics. So you have lessons learned, and you learn that based upon the data collection. So.
Well, Dr. Whitley Williams already said some things about some of the safety follow-up that's happened. And Dr. Wallace already said some things about how you define efficacy. And so maybe I could go over a couple of other things. When vaccine trials are done, when it's actually a research program, not just the emergency use authorization rollout, people have complete physical exams. They have complete set of blood work that's followed throughout the course of the study. And those data are entered into electronic medical records and databases that can be collated and compared to all their immune response data, whether they end up getting sick or not. If a person does get sick, all the symptoms are recorded for what's either a local reaction like soreness or swelling or redness or pain, and their systemic reactions, which could be a headache or fatigue or muscle aches or sometimes a fever and some chills. All those things are recorded in a database that can be looked at in every different way. And it's and the demographic characteristics of the volunteers are you attempt to balance those between groups. So, you balance it by gender, by ethnicity, by age, by other risk factors. And so there is a standard and, way of collecting this type of data in clinical trials. It's been done and it's getting better and better as our electronic database systems are improved. And so there are a lot of data being collected, and a lot of the side effect data now is being captured by this VSafe app that Dr. Whitley Williams was mentioning. So there will not be any lack of data. I'm pretty sure that the samples and the data from these 5 big efficacy trials that have been done are going to be studied for the next couple of decades to understand all that's been happening.
Okay. Anybody else wanted to comment? No? Okay, a question from the chat box. Can adverse reactions happen months or years later? And if so, how, if they happen over time, what is the recourse for those vaccinated?
99.9% of vaccine reactions happen within the first 6 weeks. And that's just been historically true. And so it is not very common to have something that could be attributed to a vaccine that would happen later than that, because most of the vaccines do not stay around very long. They're there, you get a reaction, and then they're gone. So, time will tell, but if you have something that happens at a distant time point, it's going to be very hard to know that it could have been related to a vaccine, and it's very, very unlikely.
Yes, thank you. Yes.
I just wanted to mention, because I'm not sure if I heard something underneath the question as well, and that there are programs in place to provide support for people receiving vaccine injuries. Mm-hmm. So that there are federal programs to provide support to people and around this. So this has not just been established for COVID-19. This is pre-existing. Yes. So this is a longstanding program. So,
but having reactions months to years later.
Well, yeah, I just wanted to comment on the injury piece, for people who, yes. Just to know that there is some recourse there.
Okay, good. Let's see. Are there other vaccines in the pipeline?
Yes, the WHO landscape analysis says there's more than 260 different coronavirus vaccines being developed around the world, and more than 80 of those are already in clinical trials. More than 11 are already in phase 3 trials, and the 3 that we mentioned tonight, plus one other whole inactivated vaccine, are being used in countries around the world. So yeah, there's a lot of different types of vaccines being developed in it. And that kind of activity and that kind of widespread interest and capability is probably going to change the way vaccines are developed into the future. This coronavirus pandemic sort of unleashed or revealed a big capacity for making vaccines around the world.
And we've already started to see some of that with the use of mRNA vaccine technology and HIV vaccine development. So,
Okay. This is a sort of a two-part question. One, what we've already had. Now that I'm vaccinated, can I travel? And can I take my mask off? And then one in the chat, what are your thoughts on all of this increased travel via air that people are engaging in? Any thoughts or concerns?
is that a
So
question of judgment?
that was a question. But I think that the real question is talking about the safety of travel and that they have their and of course, the CDC has indicated that it is safe to travel, but you should keep your mask on and do the distancing. So what do you think about air travel? Does it matter being in the airport for all that time period or being on a plane for a longer trip than a couple of hours? Any comment?
Yeah, as a person, in addition to doing this work, I'm also a study participant in the COVID-19 vaccine trial. So as someone who has been vaccinated, I will say I'm looking forward to getting back on a plane and being able to travel, because the restrictions have been tough, and they're tough on many people for sure. So personally, I'm looking forward to getting back on the plane.
Soon, later.
But
very soon.
Yes.
I'd like to go back and emphasize something Dr. Whitley Williams said earlier about, I'm paraphrasing a little bit, but it's basically that we're all in this together.
Yes.
And
Yes.
in an airport process, and I've traveled a lot too, and I haven't done much since this pandemic started, but there's something like 700 touch points that you might have as you go through an airport and get on a plane and get off the plane and get back to another home. And so it does increase your risk when you are touching that many and contacting and interacting with that many people. It just does. And so the idea that we're all in this together means that every time there's a new infection, it gives the virus a new chance to adapt. It gives a virus a new chance to escape our vaccines and treatments that we have now, that we're lucky to have. And so my wife actually just traveled to visit our daughter who was having a medical procedure. And so I agree that once you're vaccinated, it is much safer. But it's still, until our whole community has the virus load come down, we won't really be able to get back to normal life. And so whatever all of us can do, and we are all in this together, to keep the virus down, it means it won't change as much, and it means we'll eventually get to be more normal. But I don't think I'm ever going to take an airplane ride without a mask on ever again the rest of my life.
Yeah.
Just because things happen, and I'm probably going to be a chicken about airplanes and masks forevermore.
I'm with you.
Yes. Any other comments on that? I think I agree with you. And it's airplane trip that's longer than 2 hours is a little bit suspect for me. I need more time. Any additional comments on that? Okay, I have another question here. If a person has already had COVID-19, do they still get vaccinated? And if so, how long should they wait before getting their vaccination?
So definitely they should be vaccinated. It's been shown that there is a more robust response in terms of protection and antibody response from the vaccine than there is from the natural or the natural infection. And in fact, if you've had COVID and then get vaccinated, you have a much more robust response. So definitely you should be vaccinated. The timing used to be 90 days or 3 months, but my understanding, and please correct me if I'm wrong, Dr. Graham or Dr. Wallace, even 2 weeks, at least 2 weeks, and then be vaccinated. But definitely you want to be vaccinated, even if you've had COVID infection.
Okay. Other comments?
Yeah, you just want to make sure that that any symptoms have subsided.
Yeah, absolutely, sure. Absolutely.
So
there's no confusion.
Yeah,
Yes.
at least 2 weeks for sure.
Question from the chat box. What type of precautions should dentists and their patients be taking? Which is very good because dentists is all up in your face. Who would like to address that?
There are guidelines established by the American Dentistry Association, but also in conjunction with the CDC. I actually had a dental cleaning today. They do wear the N95 mask. They also wear a protective shield because there's tremendous amount of splattering. They also have the patient wear goggles or so that the splashing doesn't go into your eyes at all. There is an iodine wash that's used. I'm not sure of the exact efficacy of that iodine wash, but they ask you to rinse your mouth out before they start, and that's supposed to, if you are infected, reduce the viral or the amount of virus in your mouth. I can't attest to that scientifically, but certainly I think any procedure where there is splattering or respiratory secretions that are spewed into the air, it's very important for the person, the healthcare worker, to protect themselves with goggles, face shield, and an N95 respirator mask.
Okay. Another question from the chat box. Are there any liability risk for churches administering the vaccine? Does anybody have comment on that?
So my understanding, some of the churches have done it with contracts through FEMA. So that my understanding is that a liability is covered through that federal contract. And I'll stop there. That's about all I can say.
Okay.
We are also working on this with our church, and to receive vaccine from the state, you have to be a certified recipient. And so churches usually have to team up with a group that would be coming from a hospital or a clinic or the National Guard or some group that are licensed or certified to receive the vaccine, and then would also have the professional credentials to come deliver the vaccine. So it's not a simple thing to get that done if you're not a healthcare center.
Yeah, and Dr. Graham, that's exactly what was set up through FEMA. The National Guard came and that, I guess, qualified for that faith-based organization to deliver a vaccine. And
the vaccinators also go through a training process before they can give the vaccine.
Exactly.
Okay, well, we're getting close to the time. Let's see, I have another question in the chat box, and it's related to, has any research been done showing that cloth masks are better than paper masks? And any research being done on masks at all?
I'm not sure I'm the expert to answer this one. But you can visit the cdc.gov website. They have a whole explanation on masks and which ones are better. Obviously, the N95, the respirator masks, they're actually matched to your face. You actually go through a training, takes about a half an hour, and that's to make sure that there's no air leakage and so forth. Those are probably the best to use, but for the general public, no, it would be a surgical mask or another mask covering the face. But there are definitely more effective materials than others. I don't know.
And there have been some anecdotal studies about one type of material versus the other in terms of the breathability of those masks. Yeah. Other comments on that? Okay. Any thoughts on, and this is from the chat box, regarding vaccinated people gathering inside, in what numbers? Also within the dance community, touching and holding hands. Who would like to comment?
All I can say is that we're all in this together, and limiting your risk as much as possible is I think what we'd all like to have happen so we can get back to our lives again.
Exactly.
Very much so.
Exactly.
So I would like to ask, because I think we have about 5 minutes left and we're coming to a closing, if I'll go around and ask for final comments from my panelists. Dr. Whitley Williams, I'll take you first.
Absolutely. So I think it's from a pediatric perspective, it's so important to really look forward to reopening the schools. It's an economic reason. There are parents who have to stay home with the children. And in fact, they need to work. There are children who get their breakfast and lunch at school, and with the food shortage, or families being able to buy food because they're unemployed, it's very important that some children, even before the pandemic, they depended on schools for 2 good meals a day. It keeps the children occupied. Some parents don't have the electronic or the internet capability or money to pay for internet at home. So some of our children, really, there's going to be a gap in education. So there are many reasons to reopen the school. So I'm hopeful that the trials will be completed in children and we'll be able to start vaccinating school-age children. So it will be safe for both teachers and adults who work in the school, as well as the students, to return. And again, I just cannot emphasize enough for the good. Let's do this and get rid of this pandemic. And I'd like to thank you, Dr. Brown, also for having this forum. They were excellent questions. Thank you.
Thank you. Dr. Wallace.
Yes, we are all in this together. And certainly we do need to do all that we can to support our own health as well as the health of our families and communities. And I would just leave by saying, continue, for everyone out there, continue asking the tough questions, continue to stay engaged. For those of you who are interested in learning more about, the science and the technical aspects of this, there are resources to do that. Check out blackdoctor.org, preventcovid.org. NMA.org and other organizations who are connected to this process, and that there's opportunity for everyone to be actively engaged. That is the point of this, is to increase transparency in this process to ensure we're all connected and we're all moving forward together. Thank you again.
Thank you. And Dr. Graham, and I'm going to ask that because I see we have less than a minute here, or just over a minute, to put up the slide with the resources so that people can have a link to those things. Dr. Graham, your final remark.
And thank you, Dr. Brown, in case I run out of time, because you have done a great job at moderating this and even answering many of the questions. I think what I would hope people can take away is that coronavirus is a serious disease, even in young people. We've had almost 300 children die of this disease, which is more than all the deaths from influenza, RSV, and rotavirus combined. And in young people, 20% have long-term symptoms. And you know that mortality is 1 or 2% from this infection, and higher in older people or people with risk factors. And so the choice you're making is not to get a vaccine or not to get a vaccine. The choice you're making is, should I get a vaccine or will I get infected and take the risk of that severe disease? And so that's the thing I would like people to consider.
Thank all of my panelists, and I'll say to my audience, do not be part of the fourth wave of this COVID infection, giving us another surge. Wear your mask, distance, and please get the vaccine when it is available to you. We want to have a wonderful summer, and that means we must control this disease. And tune in frequently, look at the resources that we have there. Do your part. As you've heard my panelists say, we're all in this together. And if we work together to stem this disease, we will come out a champion. Thank you all for listening and have a good evening.